go through the only GI net, but I want you to focus on few take-home message for every type of gastrointestinal net. So this is the classification, so G1, G2, G3. When you have G1 is low grade, so the KI67 index is less than 3%, G2 intermediate, so KI67 is 3 to 20, and then the high grade is G3, when KI67 index is more than 20%, meaning that there are more than 20 mitoses. But how are you going to manage this net? So for example, gastric net. Gastric net, they behave completely different from the rest of the net. First of all, it's very easy sometimes to find a gastric net. You can find this nodule here. But this is more difficult to be found. And this is, in the context, much microscopic net in the context of atrophic gastritis. So what happened? So atrophic gastritis and atrophic gastritis, it's a very important to do staging and then a proper treatment. So we have the green light, and if it's green, then you have a G1 net. So staging based on dimension. If it's yellow, you have G2, so intermediate. If it's red, you have G3. G3 is a high risk of lymph nodes and distal metastasis. G2, as we'll see, it's intermediate risk. And dimensions are important because the smaller it is the net, the more innocuous it is, the bigger it is, then the higher the risk of metastasis. I mean, gastric net is a bit of a headache because you have G1, G2, G3, and then you have type 1, type 2, and type 3. So you can have G1 and type 2, G2 and type 1, G3 and type 3, or G3 and type 1, and you're telling me, I don't understand. I mean, how can I make a differentiation between? So if you give me 2 minutes, I'll tell you how you make a differentiation, and it's going to be very, very easy. So first of all, location. So you have type 1, 2, and 3, okay? Location type 1 is corpus and fundus, type 2 is all over the stomach, type 3 is only antrus and corpus, okay? That's not enough though. It doesn't help you to make a differentiation. So the other important thing is that type 3 usually is only 1, and usually is bigger than 2 centimeters, and usually is ulcerated, which means that it's nasty. Now, what are other factors that might help you? So type 1, they should be, as we saw before, chronic atrophic gastritis and anemia. And this is only type 1. So if you have a net in a patient with chronic atrophic gastritis, then that's type 1. You don't need even biopsies. If you have instead a gastrinoma or other MEN syndrome, then this could be a type 2. And type 3, as we said, is sporadic. But you know type B, you want some test. So type 1, you have increased gastric concentration, and gastric pH is high. Type 2, you have high gastric serum gastric concentration, but gastric pH is low. And type 3, everything is normal. So based on this, you can make a diagnosis of type 1, 2, and 3 without need of biopsies regarding the time. And why is this important? This is important because not just for the differentiation, but because of the prognosis in the last line. Because type 1 have a very good prognosis. Type 2 is good, but there is a 10 to 30% risk of metastasis. And type 3, there is a very high risk of metastasis. So this will influence how you're going to treat this net. So type 1, as we said, is overall a benign disease. And this is what the net guidelines recommend. If you have type 1 net, which are G1 or G2, and they are within 20 millimeters, with no lymphovascular invasion, and with no muscle involvement, then you can remove endoscopically. If you have type 1 G3, which is smaller than 10 millimeters, then you can remove it endoscopically, of course without lymph node metastasis or without distal metastasis. Anything that is above 20 millimeters goes for surgery or for medical treatment, and G3 that are above 10 millimeter that have involvement, then they go for surgery. Type 2, you don't touch them. That's it, finish. So type 2, you don't care, you leave it because they need medical treatment, because they are associated with other diseases. And as we say, type 3, then it's another story. Meaning that if you have type 3 but it's G1, G2 and they're smaller than 10 millimeter, then not involving lymph nodes, then you can do endoscopic resection. But if he's type 3 and he's bigger than 10 to 20 millimeter, then he goes for surgery. I hope it's clear. Now, what about endoscopic resection when you have type 1 NET, for example? So there is a debate, EMR, ESD was the best treatment. The data show that ESD has a higher endoscopic curative resection, so R0 resection than EMR, but that's really depend on the center. If you use MR, please use modified EMR, like cap-assisted or bundle ligation, but I would recommend ESD or EFDR. How does it work? As you know, you probably saw ESD. This was one of our first cases at the Royal Free. It's a gastric net. So you go ahead, you do, you demarcate your lesion, although it's quite visible. Then after lifting, you proceed with submucosal dissection. And the problem with the submucosal is that, first of all, you should do a EUS before attempting an ESD to check if it involves the muscle layer. And second, there will be a lot of fibrosis. And this might make the procedure a bit more complicated, but usually, most of the time, you are able to remove it properly. But what if it's involving the muscle layer? And I know you know this procedure very well. We published in Endoscopy, and this was the first case of intramuscular dissection in the stomach. And Ed did it. And that was a nice net, 15 millimeter in the gastric body. So after injection, there was mucosal incision and then trimming of the mucosa, and then it started the submucosal dissection. But guess what? The lesion was involved in the muscle layer. So what Ed did is he started to make a delineation. So here you have the mucosa and submucosa. Here you have the superficial layer of the gastric muscle, so the inner oblique layer of the muscularia propria, and here you have the middle circle layer. So Ed here is trying to dissect between the two layers, and when we go along, you see that this distinction will become more and more clear, so that at the end, he was able to remove it completely. And as you can see here from the histological images, you have a net completely removed, is an R0 resection, but you have also part of the internal muscle layer. Okay? This is of course not, I'm not suggesting that you should be that aggressive. It's only for very few cases and only for experts. And now, we also did a study where also Marcel took part. This is one of the largest multi-center retrospective study of gastric ESD net, and what we found is that we achieved endoscopic resection, R0 resection in 80% of the patient, but vertical resection was in 12% of the patient R1. So 88% of the patient had R0 resection with ESD, and this is why we recommend ESD. And of course, dimension and KI67, they influence a lot these resection results. Now, and this for the gastric net. Duodenal net, I'll give you 3 slides and I'll tell you 2 things. One, first of all, you have to go through the classification, grade and dimension as I showed you before. Second, duodenal nets, they behave completely different. So everything that is above 10 millimeter, you don't touch it. Because there is a very high risk of already lymph node metastasis. So you don't touch it, and everything that is lower than 10 millimeter, then you can think about, guidelines suggest EMR USD. I would recommend probably EFTR in these cases. But why ESD not? ESD can be recommended, but in very few hands, because ESD, from a Japanese meta-analysis, show that there is a 15% risk of perforation. So even in very expert center, there is a very high risk of perforation. So ESD should be carefully considered. As we show in this other multi-center study that where we participated, out of 15 duodenal ESD done in Western centers for duodenal nets, we had 26% of perforation, and vertical R1 was 53%, so a non-curative was 80%. So it's not just the fact that it's very risky, but that you ended up with a lot of perforation, but you have also a lot of non-curative resection. So you have to be very mindful of the characteristic of the nets, the dimension and indication. So, and then there is a growing body of evidence in the net world about how you manage the nets, because nets in the small bowel, especially if they are small, they might grow slowly and they might not give distal metastasis, especially if the patient is an elderly patient. You're probably going to avoid and use a conservative strategy, so watch and wait. Now, small bowel, one thing, and that's the take-home message. You don't do endoscopic resection in the small bowel. As Ed will show you later, you do DBE to find the lesions, to place a tattoo eventually for the surgeon if surgery is needed, but you don't resect because there is it's basically you're going to be able to cause a perforation essentially. So that's it for small bowel. And then we talk about the rectal net. What is this? It's a rectal net. Of course, I think this guy is stupid. Of course it's a rectal net. I'll tell you why I asked this question. Because from a French multi-center study with 345 rectal nets, 82% were misdiagnosed. So 82 times out of 100 when you saw this lesion that I just put out were not recognized. So majority of us, of endoscopists, we miss this lesion, and what we do is, oh, this is a polyp, I remove it from the rectum, and then guess what? It's a net. So it's important to carefully assess the polyp, the small polyps in the rectum, and the appearance is very important because you have this yellowish sessile polyp, very small, and then if you can see, there is the pit pattern. It's not like an adenoma. The pit pattern is different. So check with your NBI, with the chromendoscopy, and if you have any doubt, take your biopsy forceps and touch it. Don't take biopsies, just touch it. And if it's hard, it's a net. So that's it. Don't touch it. Send it to the net MDT to discuss it, or send to a referral center, but not remove it, because most of the time when someone removes a net, it's going to be an incomplete resection, causing a lot of problems. So, and also location. 87% of the rectal nets are in the mid part of the rectum, are in the mid rectum. So again, we have our traffic lights again, but guess what? There is no type 1, type 2, and type 3 in the rectum. So the rectum is very, very easy. So you have G1, G2, and G3, which we have already discussed. And dimension are important, as I said in this editorial that I wrote for GIE. Why size matter in this case? Because if you have a small net, then which are the majority, then the risk of having distal metastasis is very low. If you have a big net, more than 2 centimeters, then you have 60% risk of distal metastasis and 20% of lymph node metastasis as diagnosis. So you don't touch the rectal net, but you are very careful with the size, because this will help you to understand which net you're dealing with. And then what you do, if you have a net that is smaller than 10 millimeters, then you can remove it with the MR. But please, use a modified EMR, so cut PMR, add ligation, etc., although we still prefer ESD. And why is that? You use these modifications because this will probably allow you to have an unblocked resection. So you just release a band, and once the band is released, you place a snare underneath your net, you close the snare, and you cut through. Sorry, I want a bit. And you cut through. And this will help you to have a better resection, a higher chance of having a better resection. What about the net between 10 and 20 millimeter? Yes, you can remove by MR, but we would recommend you to remove by SD, because this net tends to grow very deep in the submucosal layer, and sometimes they involve the muscle layer. So what you can do is you can do an EFTR, as shown here. EFTR is very easy. You bring the net in your cup for EFTR. Once you have the net well placed in your cup, then you release the Ovesco clip that will close underneath the clip, and few second moments you close your snare and you cut. It's just about seconds. This procedure, you need to have another endoscopist next to you because you need 2 hands, but 3 procedure, 3 FTR, 4 FTR, and you know how to do it. The training is very easy. And then, of course, we saw before, we have the ESD for rectal nets, which are difficult because there is a lot of fibrosis, and that makes things more complicated. And sometimes you have to dive deep into the superficial muscle layer and perform intermuscular dissection. More than 2 centimeters, you don't touch them. They go for surgeon or they go for medical management, so it's not up to you. You, as endoscopists, care about the 10, up to 10 or up to 20 millimeter. And this is our meta-analysis. So which strategy do you use? So EMR, just with the snare, you have a high risk of R1 resection, so modify EMR or ESD, please. And again, as showed in these various studies. And then these are the recommendations from the NET guidelines. So for NET less than 1 centimeter, as I said, modify the MR, ESD or FTR. 1 to 2 centimeter, modify the MR, ESD or FTR. We don't support tummies, but in some center where there is no expertise, that might be also the case. And for 2 centimeter, you don't touch them. What if you have an R1? That depends on the type of net you have. And if there is, hopefully there is no lymph node metastasis, because otherwise you shouldn't have touched your that net. You should have gone directly for surgery. This is another multi-center study, retrospective, that we've done in our center with the collaboration of other Western endoscopy centers, and we treated 40 ESD, rectal net by ESD, and the R1 was only 10%, and the vertical margin were 5% only, R1. But what is R1 for net? Because R1 is 1 millimeter. But does it really matter? Ed, does it really matter, the R1 resection for net? Because nets are encapsulated. So even if it's smaller than 1 millimeter, and maybe 0.5 millimeter, but then the capsule is intact, this should be probably considered still an R0. So there is a lot of debate about that, and there should be more evidence. Saying that, I think I hope I gave you the more important take-home message for all the different nets. So it's important to identify staging. It's important that you have an immunity discussion, and it's important in your mind which type of net or G-net you have to attack endoscopically, which one should go to the surgeon. So first diagnosis, then treatment. And then opt for the best strategy. With that saying, I thank for the invitation. I invite you all to International IM in Malta that I directed together with my good friend and colleague Ed. And there is, of course, always Marcel, that is been there for edition number 1, is part of our core faculty. So please save the date, come to Malta. Thank you.
Thank you very much. We still want to see if there are 1 or 2 questions, because the topic, I think, is increasing as interest, and there are a lot of people are seeing that, and young people are here, and my opinion is that don't touch with the snare before you really know what is there. I think this is the best message.
Yes.
And yes.
So thank you for that overview, really great, and thank you for showcasing our wares and expertise. So you have a gastric net this afternoon to resect live, and as you know, nets are very strange beasts. They secrete a lot of chemicals, they secrete a lot of fibrogenic compounds, which reduces the separation of the submucosa. So you have a very thin submucosa, and then the net is usually stuck to the muscle, or at least almost stuck. And although we do EID in the rectum easily and safely, in the stomach, although we've described it, and sometimes it's difficult to separate muscle layers, and it can open up and lead to a perforation. And what will you do if when doing the ESD you will find it stuck down to the muscle properly?
So that's a very good point. So you can try to dissect very close to the muscle layer, and you know, you in that way you balance safety with resection with R0 R1. If you're very expert, you can try to cut close to the, superficial muscle layer, but that's, of course, you have a higher risk of perforation. But then the question is, I think the lesion from today is going to be a G1 type 1 net. So the risk of this net is very small, so you have to balance. If you remove the net and then you send it for, to the histological specialist, to the pathologist, and this is an R1, but you remove most of the net, what do you do next? Probably watch and see, even if the patient is young, because probably it's not going to cause any harm. You watch and see, and then the many times we have done ESD on a scar because of R1, what have we found? Zero. Nothing.
Thank you for highlighting the point that we are here not to treat the polyp or the lesion, but to treat the patient. That's why, although we are experts at doing things with our hands, we should always maintain our physician background and keep the patient in the center.
Yes, safety.
And one very short. Do you prefer tunneling for this, or do you prefer to suture closely the base of this? Which one?
So for the gastric net, for the SD, I usually use the pocket clinician method.
Okay.
Even for the gastric net, unless it's too small, and then we'll do the circumferential and then close the defect.
Thank you.
Thank you.
Thank you, Alberto. So, our dear host, the President, Professor